Vitality.
Vitality Unfiltered.
Unfiltered.
With David Bauder.
Welcome back to another episode of Vitality Unfiltered. I'm David Bauder, your host today. With me from Weight Loss and Vitality, Dr. Shah from Riverhead, New York, and nurse practitioner Stephanie from Washington, D.C. Today's conversation, Genitourinary Syndrome of Menopause, also known as GSM. And we're going to use GSM on the show here because it's a lot easier to say. This is a really kind of a profound topic. It's not talked about very much, and it needs to be. And our intent is to get as much information out as possible so the patients can be proactive in managing this. Roughly 50 to 70% of postmenopausal women suffer from this condition, but only 10 to 25% are ever treated. And so there's multiple reasons why women are not treated for this condition, whether it's never brought up, it's avoided, the conversation never comes up on primary care visits, or it's just this expectation that's established saying, oh, it's just part of aging. And I'm here to tell you it's not. So to discuss this, let's get started. And Ms. Stephanie, what is GSM?
Thanks, David. Good question. If you Google GSM, it's not going to be like the first, second, or third thing that comes up what we're talking about today. That's how under-discussed and under-treated it is. GSM refers to a syndrome that many women in menopause will experience as the estrogen naturally declines. They experience vaginal atrophy with this drop in estrogen. So in that way, the tissue changes as a woman ages and goes through menopause. Along with that can come some GU, the genitourinary symptoms, as well as some gynecological symptoms as well. Vaginal atrophy can lead to dryness, decreased lubrication, irritation, perhaps increased UTIs. So it's definitely something that we're going to dive into today. Yeah.
So when you think about, so you mentioned the tissue is changing, and we're going to link this back to the low levels of estrogen without a doubt. Dr. Shah, I mean, what changes does exactly the estrogen have on the tissue? Like kind of like if we go all the way underneath the tissue, and what's the estrogen doing?
We're learning that estrogen is really important for just like tissue lubrication. And it's not just the vagina and the urothelial lining. Women endorse it all over their bodies, like frozen shoulder, for example, in the postmenopausal space, joint pain. But in the GSM scenario, that's really the concern. It's funny, not funny, but the historical term, I'm so glad we've evolved into the GSM term because historically it was just called atrophic vaginitis, which is like just kind of like a harsh way to describe this situation. It's also inaccurate because like it's not just the vagina that has the estrogen deprivation and dryness, the entire general urinary tract does as well. So when the epithelial lining has less mucosa, less moisture, robustness, so too do the immune cells. Like they're not there anymore. The microbiome is not supported as much anymore as well. So you do get dryness, trauma, microtrauma, increased UTI. For me, the most important thing is the increased UTI phenomenon. It's almost par for the course that as you get older, you will just have a UTI every year. You'll get antibiotics. You'll have more than one UTI a year. You'll get more antibiotics. Then you'll have a UTI that ends up in hospitalization and you'll require IV antibiotics. And this cascade is not necessarily inevitable. We have things that we can do.
Yeah. We talked on previous shows, we talked a lot about the microbiome, and you just mentioned that. And a lot of times people associate the microbiome just with the gut, and they think about, but it's not. It's also the vaginal canal, the vaginal tissue. And one of them, I mean, exactly, as an individual ages and the estrogen level drops, I know that the estrogen is directly related to the control of like glycogen glucose in the tissue, and that maintains health of lactobacillus. Lactobacillus, I know, lowers the pH. And so when women are postmenopausal and low on estrogen, their pH actually rises. And that creates this real favorable environment for mixed pathogens to grow that they're not controlled. Lactobacillus is the natural bacteria that kind of controls the different growth rate of different pathogens that lead to urinary tract infections. I mean, Steph, well, like when we think of this, so the main reason that women get UTIs as they're aging, is it just related to the increased pathogen growth rate, or is there other things involved?
Good question. It can be multifactorial. As Dr. Shah said, the bladder actually has a similar microbiome environment as the vagina. So if you're losing that protective, healthy bacteria, it does make a menopausal woman more susceptible to developing a UTI. Think of the bladder and vagina, the epithelial tissue, as a protective barrier. As that tissue is weakened and becomes atrophied, you're losing that protective barrier, making you more susceptible to developing a UTI from normal pathogens in that environment, external pathogens that come into that environment. So it puts women at that increased risk of developing UTIs.
You know, when I was prepping for this, kind of going back, and you were the one that said, like, we need to talk about this, you know, and as soon as I'm like, what? I'm like, oh yeah, we need to talk about this. And as soon as I start pulling stuff and we're prepping for this, I'm just like, oh yeah, we really need to talk about this. And it takes me back to when I worked primary care for many years, decades. And I'm part of the problem. You know, it's not that I discounted this, but it just wasn't something that was talked about. It wasn't something that was treated. And it wasn't something that was, you know, beat into us in school. Women need to be on topical estrogen cream. You need to think about this. What do? We run a urinalysis, we dipstick it, we see there's white blood cells, we see there's an infection, here's the antibiotic. 2 months later, the patient's right back in the clinic. They got to let's send this for sensitivity and, you know, let's go see maybe you have a, you know, resistant bacteria, right? And then you give them a different antibiotic. We do culture and sensitivity and we give them the antibiotic that treats that. 3 months later, the patient's back in again. And it's just a revolving cycle. And then ultimately that patient goes to urology. I don't know what goes on. You know, at that point, I don't really know what happens. But when we think about this, I mean, what is the risk with urosepsis? And because those were my patients.
Yeah. There's a lot of things that go on in GSM, but urosepsis is just so catastrophic on a national level. And it's not sexy. It's not talked about. I think sepsis in general is finally getting some play. You know, if you look at the HBO Max show, like there's like code sepsis. It's like people are finally, oh, wow, what's sepsis? Urosepsis kills women. It kills women. You know, you get these, like just as you described, these chronic UTIs, numerous rounds of oral antibiotics. Oral antibiotics fail. They go to the hospital. Yeah. They require IV antibiotics. Then the next year, the subsequent hospitalization, they have resistant bacteria that do not respond to your first round of IV antibiotics. Now they're in septic shock. Urosepsis transitions into septic shock very fast. You know, these bacteria are usually gram-negative bacteria that are pathogenic in the vagina and the general urinary space, and they just kill women. And exactly what you said around reactive medicine. Remember a couple episodes ago, we talked about reactive medicine. This is how I got into the space, actually. I'm not a women's health physician. I'm an anesthesiologist. I entered into the performance medicine longevity space, right? And then when I have female clients and I blueprint them and I think about what's going to take you out, GSM came in because like I know what takes women out. You know, as an anesthesiologist, I take care of women with urosepsis, you know, requiring like debridement, hospitalization, surgeries, orthopedic trauma. These are all things that I think about that a lot of other people don't think about. So for me, I'm very passionate about it, and it's just so preventable. So one of the greatest resources on this topic is Dr. Rachel Rubin. She's actually I think she's in the Metro DC area, if I'm not mistaken.
Think she's too,
but she's a very vocal advocate about this, and her group did a study that surmised that if we just routinely placed postmenopausal women on low-dose vaginal estrogen to risk mitigate against GSM, we would reduce billions of dollars worth of Medicare spending on UTIs, UTI prevention, hospitalizations, urosepsis, and et cetera. And obviously mortality as well. But as we all know, if you don't talk dollars and cents, you don't tend to move the needle. So that's why it's important to talk about the fiscal angle as well. But that's how big of a topic this is. But then also, it's also not talked about. So that's why I want to push an episode on this.
Yeah, absolutely.
Yeah.
It's so interesting, Dr. Shah, when you think of how we were all trained. We have someone who went to medical school, PA school, and NP school. We're so problem-oriented, so problem-focused. So I'm just going to say on my nursing boards, UTI comes up, the answer is going to be Bactrim or macrobid. Like it's so antibiotic focused, which is great. You want to get that culture and sensitivity. The patient comes back in a month or two with another UTI. That should really raise some red flags. I love that we're shifting the focus to preventative medicine, as you mentioned. How can we prevent this, especially if upwards of 70% of menopausal women are at risk of this and developing this? How can we not have to prescribe back-to-back antibiotics? That raises a red flag for me in my practice. I don't want to throw antibiotics at you in this population when I can prevent something. What's the underlying cause? And that's what this is all about, is getting to the root of the problem, and practicing preventative medicine.
Why isn't this brought up? Why is only 10 to 25% of the 70%? Why is it such an elusive thing? And why has it been elusive over the years? Which is kind of crazy when you think about it. It's like, this one is so simple and so easy to address.
So I had a patient last week, and it's a very sensitive topic to come in and say, I have some new onset vaginal irritation, dryness. It might not be top of mind. Sex is painful. It's uncomfortable. It might just not be a priority for women to discuss this, especially if they don't know the risk implications of urosepsis and a UTI gone bad or untreated. It's a sensitive topic. I don't think people fully understand that there's treatment available. And this is something that's not just, it's a natural age-related process of menopause, but there's something we can do about it. And it's pretty low risk, insurance will cover topical vaginal estrogen. It's a local treatment. It's not systemic. So it's very safe, and it's very effective.
Yeah. What is the effect of, what is the specific effect of estrogen on the tissue to mitigate the risk? What does it do?
It's, first of all, it's largely mechanical. When you restore the mucosal integrity and production in the vaginal mucosa and the general urinary tract, with the mucosa comes immune cells. So that whole maintenance of the integrity of the tract is very important. It'll prevent trauma. So if there's intercourse, there's no micro trauma of the urethral opening. On top of that, the immune system is there. Should something be, need eradication or something needs to be fixed, the immune system is there. So it's very simple. That's why this is so elegant. You just restore the way the vagina was in the woman's youth. And that's the other thing, this stuff is not inevitable. We have a choice. There's so much in modern medicine where it's it's a natural course, but we have options. The postmenopausal period for a woman's life could be 40 years, 50 years.
Yeah.
Women have a right to have safe sex, not uncomfortable sex. They have a right to not be having chronic UTIs. This is an option. But it's just, I think that's a part of what it is. I think it is a sensitive topic. Women are not, that's not the thing that they're going to jump out and say, for example, there's another thing that Rachel Rubin talks about, which is introital pain. And it's just pain right at the insertion of the vaginal vault. And it's really sharp, intense pain, but it responds to vaginal DHEA, and she's actually one of the pioneers in trying to push this and figure this out for women, because we need to start listening to women and allowing them the space to talk about these things. Women have suffered in silence for a long time, and now women are finally having a voice. I'm glad that there are two men on this podcast who are finally admitting that we need to be better about giving them a voice and supporting their voice. So I think we're getting better about it.
Had I just think back on, again, this is almost 30 years of primary care. This is a lot of primary care. And I'm still kind of thinking back and going how did I really miss this, right? This is one of these things that just is so simple and so easy. And maybe there's an assumption there from a primary care standpoint that this is going to be taken care on the woman's, when a woman goes in for for the OB/GYN, women exam, something like that. That's not my lane, but it is your lane. It is such your lane. It's preventive medicine, right? It is. It's it's kind of irresponsible to walk away from this completely.
Yeah, there's no reason why a PCP cannot prescribe vaginal estrogen. No. I'm an anesthesiologist, and I prescribe vaginal estrogen. Yeah, from a preventative medicine standpoint. I think part of it also maybe was, this is just conjecture, but hormone replacement therapy in general fell under a dark cloud after the Women's Health Initiative. Obviously, there was a black box warning. There was a black box warning on vaginal estrogen up until a year ago, if I'm not mistaken. for blood clots, right? And that just got removed. So like there is that like whole umbrella as well. So a lot of PCPs, doctors they just don't want to get their hands dirty with that sort of stuff. If something has a black box warning, they don't want to get involved. But if you look at the literature, the only thing that carries the blood clot risk is oral estrogen,
That's right.
as we all know.
Systemic medication.
And exactly. So, we're getting better at it. I think podcast platforms, YouTube, like we have to talk about this because it has to enter the ether. Otherwise, you have to wait for like one generation of physicians to die until the next one come. But like, women need care today.
Yeah, that's right. And then women can walk in, they can demand it.
They can demand it now.
Demand it.
Yeah.
And I think we hit on the treatment. Just kind of like frame out the treatment. What is the exact treatment? And you hit it already, but like just what is the treatment?
So comprehensive care for a woman with GSM, underdiagnosed, undertreated, is really taking into consideration what she presents with her concerns, asking about comfort, urinary frequency, urgency, discomfort, dryness, really taking, a holistic approach to this. Talk about sex, bring it up if it's a comfortable space for the woman to discuss. It's important regardless of their age. And if they're willing to, use topical estrogen, we would prescribe a regimen of topical estrogen to use either daily in the beginning and then kind of downgrade it to 2 to 3 times a week as needed. But it's really more than just ruling out, UTI antibiotic, as you mentioned. And I like what you said, David, about staying in your lane, because preventative medicine should be everyone's lane,
yep.
regardless of what kind of provider you are. I worry about, I'm very concerned with judicious prescription of antibiotics. Like I don't want to.
No, everyone feels comfortable prescribing antibiotics.
Yeah.
Everyone prescribes antibiotics.
And that should, like I said, raise a red flag if you're prescribed, the same patient, recurrent, like that's where this is kind of like, should have you scratching your head, regardless of what field you're in, prevent these things. But yeah, just treating the woman as an individual. What are her concerns? What has brought her in? Whether it is the chronic UTIs, whether it's the first time she's ever had a UTI, that should probably raise some alarm bells too. Something has changed down there. But this is a big one, and I'm glad that we really unpacked.
I also will remind the listening audience that this is one of these treatments that can be prescribed in all women. It's not systemically absorbed. So even with a female with history of breast cancer, you are not excluded from this, okay? Because this is there is such a micro amount ever absorbed in the bloodstream here. You can still get localized treatment and decrease your risk for urinary sepsis down the road just by doing this. And you do not have to, that has to be a discussion with your provider, but that doesn't mean you're excluded from this treatment. So everybody should be asking about this. 70% women post-menopause, that's a big number. Huge number. Only 10 to 25% are ever treated. That's a huge number, or very low number, right? And huge gap in care, and everybody needs to be aware on it. You guys have anything else to add?
Just real quick, just regarding treatment. Treatment's actually very flexible, and this is where I really exercise joint decision making with the patient. It depends on what the woman wants to do. There's a lot of options. So if you don't want to do the vaginal cream to properly apply it, there's an applicator. It can be complicated. Yep. Some women take to it and it's not a problem. Some are like, it's really annoying. And that's okay. Sometimes if you get systemic estrogen therapy via a patch or whatever high enough without any sort of breast tenderness and whatever, sometimes you can actually get some of those changes in the vagina and it's sufficient. Or if you have systemic therapy, but the moisture is returning to the vagina, but it's not quite there yet, you can still layer on more vaginal estrogen. No downside there. And if the cream is not great for you, there are other modalities as well. You can do vaginal capsules and tablets that are inserted. There are rings and devices that you can insert deep into the vagina that sit there and last 30 days. So it's there's a lot of options. And you just have to learn about them, inquire about them. And as a provider, again, I'm not specifically a women's health provider. I practice preventative performance medicine for all of my patients. Half of my patients are women, and they deserve that same level of, fidelity of data-driven medicine. So that's what I practice.
Yeah, they definitely deserve to not be discounted.
Exactly.
100%. Steph, you got anything else?
No, the other thing I would add to Dr. Shah, though, is most every modality that you mentioned, I've had covered by insurance.
Yeah, exactly. It's not expensive.
No brainer.
Yeah, absolutely.
Easy.
And even if it wasn't covered by insurance and you don't have insurance, it's not an expensive treatment.
Right.
It's
cheaper than an ICU stay.
Very, very much cheaper. Or with that, so I just want to close out saying, aging is normal, but suffering is not. And so this is something that has to absolutely be taken seriously. I want every single listener out there to be aware of this. It's good medicine, it's preventive care, and it's easy to treat. And if you enjoyed listening to the show, make sure you hit the subscribe button below. I'll see you on the next episode.
Thanks for joining us on Vitality Unfiltered with David Bauder. Addressing norms, busting myths, and uncovering health realities for a more vibrant life today. For more expert insights and real talk, make sure to subscribe and join us next time.